Professor, go ahead and speak.
Yes, we can.
Hello.
Hi, Benjamin. Thanks
Can you
for
hear
joining
me?
us.
Hi, how are you?
Good.
I'm very sorry not to be among you. It would have been a pleasure. And sorry I have to be online. But thank you very much for the invitation for this specific topic. And optimization is the, let's say, the good language according to pharma to speak about de-escalation, but my talk will be about de-escalation, obviously. This is my disclosures, and as you can see, all the money goes to my institute, not to myself, so I'm pretty free to speak. De-escalation is not a new story, and I will take a few examples. Lungart is a radiation trial. The goal was to understand if after resection of N2 non-small cell lung cancer, adjuvant radiotherapy matter or not. That was the primary endpoint of the trial. At the time the trial was done, roughly half of the physicians were used to provide adjuvant radiotherapy for these patients, the N2 positive resected non-small cell lung cancer patients, and half of the community was more, okay, let's just watch and wait. In fact, it's a superiority trial, but in a way, it answers a question we raise in a lot of tumor board. And if you are part of the team doing in your routine practice postoperative radiotherapy, you can call that a de-escalation trial. The trial is positive, is negative, sorry. The overall survival is similar. There is a bit of better control, but overall it's a negative study. And you can say for those who used to give adjuvant radiotherapy that it's a de-escalation trial. Well, the theme of de-escalation came obviously with immunotherapy, and this is an example of India where immunotherapy is not covered by the health system, so only less than 3% of the people can afford immunotherapy. So there is a huge issue with drug access for immunotherapy, but in fact for most of our drug in oncology. So if you like, I take the example of immunotherapy and targeted therapy. How can we optimize treatment strategy? And the first possible thing is to act on those. It's good to know that I think as academic researchers, we might have been a bit lazy on that. Let's take the example of bevacizumab. Bevacizumab was developed in lung cancer at 2 different doses, 7.5 and 15 milligram per kg. The meta-analysis show no, you see the 2 boxes are the 2 doses. There is no striking evidence that one dose is superior to another. And the drug is approved with 2 different doses. Maybe we can have a step back and say, isn't that crazy for such an expensive dose at the time to have a label by EMA that is choose what you want, simple dose of double dose, and we don't know what is the evidence, and we don't have the pharma to generate the evidence. And the only randomized trial that have been done looking at the 2 different doses is shown there, but the primary endpoint was not to show superiority of the high dose. The primary endpoint was interaction with biomarker. So by the book, you cannot say that this randomized trial allow you to say the low dose is enough. Why the academic community didn't run this trial? Because the thing is, if 7.5 seems to equal 15, maybe 5 is enough. And we could have done the escalation trial and save a lot of money, but maybe we're too lazy and we prefer to pay. Pemetrexed has been tested as a higher dose. So 500 was randomized between versus 900 milligram per meter square. It's exactly the same survival, and it's exactly the same toxicity. Why? Because there is an active transfer of the dose in the cancer cells, so that whatever the dose you give, the effect to the cancer cells is the same. Isn't that crazy? We don't see that so much. A trial where you test the standard dose and almost the double of the dose. But if these two are equivalent, maybe we could have asked that lower dose would have been enough. And again, we would have saved a lot of money. But again, my take is maybe we're a bit too lazy and we prefer to pay. If we look now at the data on immunotherapy, it's super interesting to look at nivolumab. A very nice way to look at the biological activity of any PD-1 or PD-L1 blocker is to look at the PD-1 occupancy, and it's very easy. You do it on the circulating lymphocytes. A very simple blood test. You extract lymphocytes and you look at the occupancy of nivolumab on the lymphocytes. And you can see that 0.1 or 10 milligram per kg, you have exactly the same occupancy. 100 times more immunotherapy, same occupancy. And the drug was developed at 3 milligram per kg, 30 times more than the lower dose that seems to be potent. The most interesting data came from the phase 1 in patients with melanoma. So you look at the different cohort of patients with melanoma treated at very low dose, 0.1 milligram per kg, 29% response. 3 milligram per kg, the dose that was used to develop the drug, 41% response rate. 10 milligram per kg, 100 times more than the lower cohort, 20% response. So basically what it says is that probably 0.1 milligram per kg, 30 times less than the approved dose, is enough. In renal cell carcinoma, they have tested in a phase 2, 0.3, 2, and 10. So there is a difference of 33 times between the low dose and the high dose cohort, and it's exactly the same survival. And it was developed again at 3. And I think looking at this data, we must say 3 is probably too much. Pembro was tested 2 versus 10 in lung melanoma. 10 was not considered better, so 2 was used as the standard dose. And then we move to the flat dose area. This is the standard weight across the globe of healthy people. This is the drug dose that were developed as flat dose. So nivolumab considered that any patients will weigh 80 kgs. Pembrolizumab considered that any patients would weigh 100 kgs, which is, I think we agree, at least in Europe, maybe a bit too much. And if you look, for example, on the weight, the average weight in Europe of a healthy female, it's 70 kgs. We have done the job at Gustave Roussy, and we look at the weight of our patients diagnosed with non-small cell lung cancer. And the average weight of women diagnosed with non-small cell lung cancer, metastatic, so eligible for a first-line immunotherapy, is 50 kgs. So when you give 200 milligrams of pembrolizumab, in fact, you give twice the dose that was developed to demonstrate pembrolizumab efficacy. So obviously, we give too much of this drug to the patients. So in India, because of the issue of drug access, they did a very interesting trial with an ultra-low dose of nivolumab, 20 milligram each injection instead of 240, which is the flat dose used. Meaning that with a vial of nivolumab, you don't treat 1 patient, but 12. So it was patients with head and neck cancer, and they were randomized after failure of the first-line treatment between a palliative chemo and palliative chemo plus this very low dose of nivolumab, and it improved PFS and OS. So obviously, In Europe, this would not be possible. What would be possible is to compare the standard dose, 240, to the ultra-low dose. If you just look at the shape of the curves, on the left side, you have the registration trial with the standard dose of nivolumab, and on the right side, you see the ultra-low dose trial from India. It's striking to see that the shape of the curves are exactly the same, separating quite late, around 5 months, and the hazard ratio is roughly similar. But of course, formally, we have to test low dose versus high dose. A phase 3 has been developed in India based on these preliminary results, looking at second-line treatment, nivolumab single-agent ultra-low dose, or physician choice chemotherapy. Most of the patients enrolled, more than 50%, had head and neck cancer, 36% lung cancer. While it improved overall survival, which was the primary endpoint, but no benefit on PFS, but yes, ultra-low dose works. Again, control arm is not standard dose. Cost saving is massive. Almost more than 86% of the cost is saved. So it's really something we have to consider. In the neoadjuvant setting, there is only one study, but it's not randomized. It's a propensity score matched analysis. And it suggests that compared to chemo plus ultra-low dose of immunotherapy might have a benefit. There is one trial ongoing that has been partially presented. This is the dedication trial from the Netherlands. So here it's stage 3 and 4 patients with lung cancer eligible for standard dose of immunotherapy randomized to standard and reduced dose of immunotherapy. So there was an interim analysis just to be sure that there was no deleterious effect of the low dose. So what is presented here is the interim analysis. So it's not so much patients, 123 per arm. And what it shows is that if we apply the rule of the interim analysis, there is no futility. So there is no decreased benefit of the low dose arm, so that randomization can go on and the trial is still ongoing. So this is only to say this is not definitive pictures. This is not to say that early look at the population says that there is no deleterious effect of the low dose. There are a lot of retrospective data that shows just that low dose equals standard dose. But of course, it doesn't apply to all drugs. We know, for example, that ipilimumab is closely related to the dose in terms of both toxicity and efficacy. So we should never de-escalate ipilimumab, probably, at least in terms of dose. So if you choose a drug you want to de-escalate, you need to have very strong biological argument, but not all drugs are eligible for dose de-escalation. Osimertinib is another interesting example. If you look at the phase 1 data, the response rate to 40 milligrams per day is equal to 80 milligrams per day. I heard the discussion you just had, and there was a discussion around funding. And the Netherlands, you know, this country is quite pragmatic, but I think Ireland is too quite pragmatic. But what did the Netherlands is they said, we have a problem with osimertinib because we spend too much of money. So the health insurance started a call and asked physicians in the Netherlands to build a trial of de-escalation of osimertinib, and they say, build a trial and we will pay. Why? Because in half of the population, in the experimental arm where you de-escalate, you will give less osimertinib, so you will save money. And the Netherlands, they said, okay, if we save money running a trial on our global expenses, let's re-inject this money and fund the trial, which is extremely smart. And it's the only country that was brave enough to run such a call. So my friend Anne-Marie Dingemans started to say, okay, let's do that. let's do a trial where you start with the standard dose of OSI, and after 6 months, if there is no progression, let's randomize between half of the dose and standard dose of osimertinib. The cost of a tablet of osimertinib in the Netherlands is 205 euros. So what is the cost of the tablet of 40 milligrams of osimertinib compared to 80? What do you guess? You have also that in Ireland. What is the price of the low dose osimertinib compared to the high dose osimertinib? Guess what? It's the same. So if you do a de-escalation trial where you will say to one population, take the 40 milligram pill and 80 milligram pill to the control arm, there will be no reduction of cost. So what Anne-Marie said, she looked at the half-life of osimertinib, which is quite long, almost 50 hours. And she said, okay, long half-life. So in the experimental arm, I will de-escalate, giving not OSI every day, but every other day. And with that, you decrease by 2 the quantity of osimertinib given to the patients, but also you decrease the cost by 2 of the treatment. And the trial is ongoing in the Netherlands. The second way to act for de-escalation is to optimize the schedule. Why we can optimize the schedules? Because if you inject one shot of nivolumab to a patient, the lymphocytes will have a saturation of PD-1 during 100 days. One shot, 100 days of saturation, and we cycle the patients in each 21 days, which might seem to be not really logical, but this is what we do, and this is how the drug are developed. And apart from avelumab, all the drugs that we use today, they have crazy high half-life. So the cycling every 3 weeks is probably not the optimal one. In the UK, the REFINE trial is testing this hypothesis. So it's pembrolizumab 600 milligram given each 6 weeks in the control arm and given each 12 weeks in the experimental arm. If there is a non-inferiority analysis that is positive, they will even expand to more increase duration of increase interval, between injection up to 18 weeks. In France and now in Europe, we run the PULSE trial. Patients with non-squamous non-small cell lung cancer started the usual one, chemo pembro, 3 to 4 cycles, and then they are randomized between pembro at 200 milligram every 3 weeks, plus pemetrexed if needed, obviously, and pembrolizumab 200 milligram, but every 6 weeks. So in the maintenance phase, we de-escalate the immunotherapy pembro by 2. We have evaluated the economic impact of this strategy and the saving in France, given our population. We have 40,000 new cases of lung cancer each year. So in the metastatic population, that might be half, maybe. We have evaluated what would be the cost saving of this, and this is 1 billion euro each 3 years. 1 billion euro each 3 years. The savings are absolutely massive. There are other initiatives in the US, again, playing with the interval and not the dose. What about TKI in melanoma with a BRAF mutation? A combination of a BRAF and MEK inhibitors are standard of care. So there were some biological studies, preclinical studies suggesting that intermittent inhibition of BRAF through the BRAF-MEK combination could be superior to continuous treatment, preventing some resistances. So in a trial, they have compared continuous treatment of BRAF-MEK versus intermittent treatment, 4 weeks on, 2 weeks off. Unfortunately, the intermittent regimen was much worse than the continuous regimen. So not all good ideas based on preclinical study translate in a benefit or in patients, and in this case it's a loss of benefit. Interestingly, the rate of grade 3 plus toxicity was similar between the two arms, so absolutely no benefit. Last way to optimize the treatment is to act on duration. We know the Checkmate 153 trials where there is a sub-study where patients were randomized between 1 year of nivolumab versus more nivolumab. That was at the time of the second line plus nivolumab. And there was a benefit to continue nivolumab, but the quality of the trial, because it's a secondary endpoint, is very weak. So there is a retrospective data. The first data sets come from the US, 14,000 patients starting immunotherapy. At 2 years, 7.5% of the patients are still on treatment. Let's look in these 7.5% of the patients, what is the benefit of continuing immunotherapy or stopping immunotherapy? Only 20% of the patients stop, but the data shows that it seems to be similar in terms of overall survival. So 2 years seems to be enough. In the French care system, we have access to any patients treated with any drug. It covers 100% of the population because we have a national system, and we can ask questions to this massive database. So we have a look between 2019 and 2023. We looked at the patients that started pembrolizumab for lung cancer. It's 43,000 patients that started pembrolizumab. At 29 months, which took a bit more than 2 years, 7.4% were still on treatment, meaning controlled. 2,000 patients go on, 1,000 patients stop. The overall survival is strictly similar. We have updated this database and we find exactly the same data. So 2 years seems to be better. There is a trial run by the French group, IFCT, with ipi-nivo, and the question was, in patients with metastatic lung cancer, should we give 6 months of ipi-nivo or more? Well, the stop and go, meaning 6 months, and if there is a recurrence, a rechallenge, was better, but because ipi-nivo was not filed at the end in Europe, the trial was stopped with only 30 plus patients per arm. But it's interesting to see that in a very small population, there is no deleterious effect of the stop and go strategy and much less side effect. IFCT is now running a trial called DIAL, where patients with metastatic non-small cell lung cancer receive chemo IO upfront, and then at 6 months, they are randomized between observation, or for the non-squamous, just pemetrexed, or the same treatment up to 2 years. The trial is ongoing. Whatever the neoadjuvant phase, we know that we have only 1 neoadjuvant study versus 5 neoadjuvant perioperative studies. In terms of benefit, there is no striking difference between perioperative and neoadjuvant. We know that there are 2 trials, pre-op or peri-op, with the same drug nivolumab. I will go a bit fast on that, but just to say that they have compared the whole commerce population in the neoadjuvant, but in the perioperative, they took only the patients able to receive at least 1 cycle of adjuvant nivolumab. So the one without any surgery issue, a very good performance status post-surgery. So only a fraction of the patients who, when they say maybe it's better peri-op, in fact, we cannot compare these 2 populations. So there are 2 trials ongoing. I call them de-escalation trial because it's peri-op versus pre-op only, the ADOPT lung ETOP study, and there is the INSIGHT SWOG study that also evaluate the same strategy. So my last slide will be just a bit of strategy. In Europe, the drugs are approved by the European Medicine Agency. And if I take the example of pembrolizumab, it's written in the label how much drug you have to give. If I imagine that my trial pulse is positive, what will it change? it will not change the label, because only the pharma company can ask to change the label. So I spent 10 years of my life running a trial, maybe demonstrating that half dose is enough, but it will not change the label, because our agency, EMEA, doesn't allow academic to question the dose. The dose has to be questioned by the pharma, and that's all. Even if it's an academic agency, let's say, it's our agency. We pay this agency, so we should have a role in the agency to say, I run a massive trial, de-escalation trial, non-inferiority, as you do for pharma. Look at my design, validate my design up front. I run a trial, and if my trial is positive, change the label. But this is not possible. So the label will always be the same. Guidelines might change, but the payers are not changing. Why? Because they are too shy or not brave enough. And there are a few countries, for example, Denmark, where they have limited the duration of immunotherapy. So when you start chemo-pembro, you are allowed only to give 2 years of pembro, which is fine. The data support that. In France, for example, you can do what you want, 2 years or more. Why the French system is not stopping that and just say it's 2 years because it has proven in our data set in France that it's enough. No, nobody does that because people are not brave enough. So in conclusion, de-escalation are mandatory, not for all drugs. You need a strong biological and pharmacokinetic rationale. I strive to be a good oncologist and a responsible citizen running such a trial, but financial toxicity will improve only if regulators and payers take action, and that requires courage. And with this, I thank you for your attention.
Thank you, Professor Besse, for this very brave presentation. We hope we can be just as brave. So with that, I think we're going to go to our next speaker, and then we'll take a Q&A.